efficacy were independent predictors of smoking cessation after AMI. So we made some recommendations. First of all, to conduct further studies to explore reasons, obstacles for not providing recommended standard smoking cessation services to AMI patients, to further explore smoking cessation practices among AMI patients, and to investigate smoking cessation practices in other medical settings among patients with AMI. And integrate recommended standard smoking cessation services into medical care for all AMI patients, and implement assessment of nicotine dependence level or self-efficacy of patients to identify those patients who are more likely to continue smoking and provide more intensive assistance to them. Thank you for your attention.
Thank you, Vartuhi, for the interesting study.
Thank you.
I have 3 questions actually. The first one is how you defined quitting smoking, because some patients tell that they quit smoke for 1 day and they then continue. There should be criteria.
Mm-hmm.
For how long period they shouldn't be smoked?
We took 1 month, 30 days. According to some studies, it is used in the literature, and I asked the question for this period of time.
Okay. The second.
Could you please elaborate? Because I know you investigated for those who quit it, you asked when they quit. Can you present that information to the audience?
All of the quitters quitted right after the hospitalization, and there were quitters sustained their quitting status. So.
Okay. The second one is, have you investigated the association between the severity of the myocardial infarction?
Yes, the association was not significant.
It wasn't. Okay, because I haven't seen this variable. And the third one is how self-efficacy was measured.
This is a 12-item scale. 6 items measure their internal stimuli, like how they could retrain from smoking in difficult situations where they are depressed or nervous. Sorry. And the 6 other questions measure their how they behave when they are with smokers, when they are drinking coffee or other external factors. And so this is a 12 items scale which has points from 0 to 48.
It's been, yeah.
It is widely used in the literature. In Armenian, no. Yes, it is validated.
Have it been used ever in Armenia, among Armenian, or you translated it first time?
I translated it.
Yeah, okay, and
thank you, Vartuhi. You mentioned that 85% of participants use their willpower to quit smoking, right? And only 1 person used nicotine replacement therapy.
1 patient.
1 patient. Yeah, this is what I'm saying. So, how about the rest? What were the strategies that they used?
Some of them mentioned that this is not difficult, they just don't want to quit. Some of them mentioned that they try to be apart from the smokers, and some of them mentioned that family members help them not to smoke. So, but mainly they mentioned their willpower.
Okay. My next question is about your recommendations. You said that so the providers do not do the counseling according to recommended standard. So is there really such standard in Armenia currently, or is it's up to the providers whether they counsel on quitting smoking or not?
It is up to the provider, because here in Armenia the standards are not integrated in the medical centers.
Thank you, Barty. I have a question. So you initially your sample size was how many participants you were intended to enroll?
From the preliminary information, we expected to have 215 patients.
And I wonder, have you had a chance to calculate power for this number?
I calculated power for one of our independent variables. It was 0.58.
15. Thank you.
Thank you for a very clear discussion. I have two questions. I'm wondering if you can go back to your multiple variable regression slide for a second. And can you explain, yeah, that one.
This one?
Yes.
Mhm.
And I know that you had to go quickly because of time limitations, but can you say just, a little bit more about statistical versus clinical significance, and if you see anything else that might be going on in the data that you would want to investigate in future studies, even if it's not statistically significant here?
Mainly, those variables are consistent with the literature, and the odds ratios were consistent with the literature, and we didn't find any inconsistencies. So our power was less. This is one of the limitations of our study, and we maybe in the future we will continue and we will expand our study sample size, and we'll do further calculations.
Do you think you could make any sort of theoretical, or give some thoughts perhaps about the association between the odds ratio that you see for household monthly income and the possibility of its relationship with self-efficacy and with quitting smoking, and how you might study that in the future? In other words, how do you think that operates?
Sorry, I didn't.
So you've got
2.31.
2.3 as an odds ratio for the higher level of monthly income. It's not statistically significant, but it's interesting. And I'm wondering if you can just maybe talk for a minute about what you think might be going on there, if anything, and how you might study that in the future.
Maybe the solution for this will be to further investigating, but for now I didn't know why this could happen, actually.
Okay. My second question is, you may have partly answered it a minute ago and I just missed it, but around the psychometrics, especially of the CESD, you said that the psychometrics of the CESD, you said that it has not been validated for an Armenian population. It seems to me that you might have enough data yourself to start to look at the reliability and validity. Have you considered that?
I didn't get your question, sorry.
Based on your own population.
CESD scale was validated, yes, we considered the validation, and
in Armenia, your version of it for this population.
It was validated, yes. Not self-efficacy, yes. The self-efficacy scale was not validated, but the depression scale was validated in Armenian population.
Okay, thank you.
Would you consider the self-efficacy, would you consider this the first step in the validation?
Yeah.
Maybe further validation could be done, and it will be interesting because this scale is widely used in the literature and may be useful for Armenian population for further studies.
I think that would be very interesting.
Thank you.
Thanks again for an interesting study. My question, I have two questions. One is, I'm sorry if I missed it in the beginning, but what percentage of these 100 and plus patients attempted to quit smoking?
Almost all of them attempted to quit smoking. My finding was that.
And that's also consistent with the literature?
Yes.
Yes. And the second question I have for you is, how would you interpret, so self-efficacy turns out to be, as you said in the literature as well, statistically associated with those who successfully quit.
Yes.
But how would you interpret that association?
Those who think that they can refrain from smoking and who are confident that they could not smoke, they are more likely to quit smoking when they want to quit smoking.
So I don't know this field, but in the breastfeeding literature, self-efficacy is also highly correlated with successful breastfeeding. But the questionnaires are usually asked once the person has successfully breastfed. And so there's a question of whether the actual successful behavior leads to an increase of self-efficacy. So in cross-sectional data, it's hard to interpret that association because the most successful smokers now can report more confidence about their ability to quit smoking. And so I just want to be careful when you interpret. It is a statistical significance and it is highly correlated. But with cross-sectional data, it's hard to know if the self-efficacy was there first and led to the quitting or vice versa. Yeah.
This is one of the limitations that these measures retrospectively, and we couldn't get.
Yeah, no, I mean, we have that same problem with breastfeeding.
Yes.
And we find actually that measuring self-efficacy during pregnancy is not always correlated with successful exclusive breastfeeding. So because if we can do cohort studies, so it's just interesting. You can't find somebody before they had a heart attack, of course. But yeah, but it's just be careful with your interpretation of that. Yeah.
Thank you.
Okay, you're done?
Yes.
So the first two presentations were about patient perspective. Now we have a presentation on providers' perspective by Shabita Alexander.
Hello everyone, thank you for giving me this opportunity. Today I'm going to present you about my thesis, which is about knowledge, attitude and practice towards evidence-based medicine among general practitioners and specialists in Erevan. The outlines are